Hello, everyone.
Hi.
Hi, my name is Kate Sullivan, and I'm co-organizing this webinar with Joyce Yu. Welcome, everyone. We have one of our largest audiences ever for this webinar, so I'm really excited that we have some amazing cases. I thought just before we get started, we would get everyone used to using the chat function. I think you can see to the left of the screen there's a small box. We'll be using that to interact with you. So I'm just going to ask for people to type in a few comments about who they are and where they're from. If you're from far away and you think you might be the farthest from, let's say, Milwaukee, Wisconsin, go ahead and type where you're from, and we'll just get people to get comfortable using Gómez. Very funny. We'll just get people used to using the chat function. So go ahead and tell us where you're from, and then we'll get started in about 1 minute. Hi, Nacho. Buenos días or buenas noches.
Buenas noches.
This is Joe Church.
Venezuela, very impressive. Hi, Zilton from Brazil. Excellent. We have some very far-flung people, and I just heard Joe Church join us from California. Anyone else from California? I see Georgia. I see New Jersey. All right. It looks like everyone feels pretty comfortable with the chat box. Oh, and Montreal. Very beautiful city up there. So we're going to go ahead and get started. As the cases are presented, we will open up the discussion in the chat box, and feel free to comment. This webinar series is supported by the Clinical Immunology Society, USIDNet, and the Latin American Society for Immune Deficiencies. And, of course, a major effort of both of the networks, the USIDNet and LACID, are registries. So I hope all of you are rolling your patients up into these registries, because it is a very important mechanism for doing research. So I welcome you all. I think this is going to be an amazing webinar. And with that, I'm going to turn it over to Joyce Yu, who's going to start the literature review.
Thank you, Kate. Let's see here. So moving on to, so tonight, just as in the other case webinars, I'm going to highlight a few papers from the most recent JOCI. So tonight I'm going to highlight 3 papers. The first one is titled Investigation of Skin Barrier Function and Allergic Sensitization in Patients with Hyper IgE. So as we all know, autosomal dominant hyper IgE is characterized by an increased susceptibility to infections, connective tissue abnormalities, as well as an eczema-like rash. On the other hand, we all know that eczema itself is associated with a skin barrier dysfunction as well as an atopic phenotype. And mutations in filaggrin have been described in patients with eczema. So the purpose of the study was to compare markers of skin barrier function and allergic sensitization between hyper IgE patients and patients with eczema. They studied 7 Hungarian patients, or hyper IgE patients. All 100% of them had STAT3 mutations, and compared them to 49 mild to moderate eczema patients, about a third of whom had filaggrin mutations. So in terms of the results, the hyper IgE patients, as to be expected, had a decreased number of Th17 cells, and they had a higher mean total IgE level compared to the eczema patients, so 8,500 versus 3,800. And none of the hyper IgE patients had either of the 2 most common filaggrin mutations that were tested. On the flip side, the eczema patients actually had a higher transepidermal water loss, that's the TEWL there, and that was measured through abnormal and normal skin, so they had higher water loss as well as a more basic skin pH, suggesting a little bit of more of an abnormal skin barrier function in the eczema patients compared to the hyper IgE patients, who are somewhat similar to the healthy controls. In addition, the eczema patients had an increased serum and stratum corneum TSLP levels, suggesting more inflammation or abnormal inflammation. And they did have higher rates of positive air allergen allergy testing. I believe they tested for cats and dust mites, amongst a few other things, as well as concomitant asthma and allergic rhinitis, as compared to the hyper IgE patients who had a lot less a lower incidence of asthma and allergic rhinitis. So one of the conclusions that the authors came down to was that the hyper IgE patients actually have a comparatively normal skin barrier versus the eczema patients, and they proposed that perhaps this kind of intact skin barrier was what's preventing this allergic sensitization in hyper IgE patients who would otherwise think would be very allergic or very atopic. And it suggests perhaps there may be a different immune pathophysiology for the skin findings in the hyper IgE patients. And it also supports the importance of a skin barrier function in developing allergic disease. So it's a very interesting paper. And moving
Joyce,
on to
can
the
I
next one.
ask you a question? So,
yes.
I don't think about eczema that much. To me, the eczema in hyper IgE just looks different. Is that a general? Do other people think that, or am I just making that up?
That's a good question.
I would agree.
I would agree too. It's funny because if you look at the papers, a lot of the descriptions, they say it's eczema. Like you look at the classic definition, it's like hyper IgE is infection, and eczema. So I guess they call it eczema for lack of a better term. I don't know. But it's pointing to the fact that there's a definite distinction, different kind of immune inflammation in hyper IgE versus eczema patients.
Mm-hmm. Okay.
If you
yeah.
eczema, it's not atopic dermatitis. If you talk to a dermatologist, an eczema is any rash, kind of itches and scaly. But I think the rash of hyper IgE is more of a chronically low-grade infected folliculitis, more than.
I think it tends to respond better to anti-staph treatments than it does to steroid treatments too, and it tends to be more red the less the staph is contained. Has been my experience.
Interesting.
Well,
thanks for those perspectives.
Thank you. I think that's one of the, I think if you read a lot of papers, they always say it's eczema-like, right? So perhaps we should maybe change the terminology of that. We should call it something else. Yes, I think that's the reason one of the points of the paper in this paper, I think. And then going to the next paper, which I thought was very interesting, it's a paper on cerebral vasculitis and XLP, which is cured by matched unrelated cord blood transplant. So as we all know, XLP is associated with mutation in SH2D1A, so it's causing abnormal signaling through the SAP protein, and it puts these patients at risk for fulminant ABV infections, HLH, lymphoma, and hypogammaglobulinemia. On the other hand, there's this non-infectious, non-immunologic complications that I was not very aware of, which are vasculitis, aneurysms, restricted joint disease, which have been described as rare complications of XLP. So prior to this case, there were 2 prior reported cases of arthritis and 4 prior cases of non-EBV-associated cerebral vasculitis, all of which in general were associated with pretty much poor outcomes overall. In this paper, they described a 9-year-old boy who had restrictive joint disease of the wrists, elbows, and lower extremities. I think at some point they thought he had JIA, but it didn't really look like that. He had 2 episodes of acute respiratory failure, but no organisms were identified. His immune profile showed an increased peripheral B cells, hypogammaglobulinemia, generally low vaccine titers, as well as an absent NKT cells. He then had 1 episode of transient aplastic anemia, which he recovered from, then developed a bunch of neurologic symptoms, including headaches, vision changes, and vomiting, and was ultimately found to have a left-sided infarct as well as a cerebral vasculitis and a pseudoaneurysm. I note in here that he was not found to have any gamma-delta T cell clones because these were found to be associated with the cerebral vasculitis in one of the prior cases, reported cases of the cerebral vasculitis. This patient had persistent HHV7 cultures in the CSF. He had gastritis, and due to decreased NK cell lysis function, they sent for genetic testing and was found to have a mutation in the SH2D1A. He was ultimately transplanted. He failed his first transplant but ultimately grafted his second cord transplant with 100% chimerism. The transplant was complicated by BK virus hemorrhagic cystitis, as well as immune reconstitution syndrome, which is thought to be due to the engraftment of the NK cells, as well as complications with anti-glomerular basement membrane disease. The ultimate outcome of this child is that his cerebral vasculitis did stabilize, and the CSF actually became negative for HHV7. So I thought this was a very interesting case that illustrates a lot of the numerous immunologic and the non-immunologic complications of XLP that I would never have thought of. So I thought it was a very good reference to pull up in case you see another patient with XLP. And the last paper that I want to highlight was a novel 10 base pair frameshift deletion in exon 2 of ICOS, which causes a combined immunodeficiency associated with enteritis and hepatitis. So ICOS is expressed on activated T cells and is important for helper T cell function as well as differentiation of the T follicular helper cells. And it's generally associated with a CVID-like picture, with the refractory diarrhea as well as later onset of infections, autoimmunity, and a risk for cancer. So the patients that they described in this report were two siblings who had parents of the same background but supposedly were not related. The first patient had persistent diarrhea, fevers, and weight loss, had hepatomegaly, a hepatitis, an enteritis picture, and was HHV6 on all her gastrointestinal biopsies. She had infections with, she was positive for norovirus, adenovirus, as well as cryptosporidium in her stool. And her immune phenotype showed no class switch memory B cells, as well as hypogam, and poor vaccine response. They tried to transplant her with a matched unrelated donor. However, due to complication with respiratory distress syndrome and TEN, she ultimately died. Her older sibling, which is patient number 2, the proband, he only just had diarrhea, but did have some elevated LFTs and was noted to have a very similar immune phenotype with no class switch memory B cells, hypogam, and very low number of T follicular helper cells. Ultimately, genetic testing was done and was found to be a homozygous 10 base pair deletion in exon 2 of ICOS, which led to a premature stop codon. One of the goals of this paper is just to demonstrate that not only do we see perhaps like a B cell deficiency in ICOS deficiency, but we can also see a picture of a combined T and B cell deficiency that's characterized by these increased susceptibility to particular viruses such as HSV, HPV, HHV, as well as other opportunistic infections. And the author speculates that perhaps the number of the T follicular helper cells may correlate with severity of the phenotype. So the fewer cells you have, the more severe the phenotype. And they do caution to rule out other causes for abnormal T cell activation first before evaluating for ICOS expression. So that ends the literature review.
I think that last case was really important. There's so few cases of ICOS deficiency out there in the literature. This one is on definitely the more severe end of the spectrum. So I think it's definitely expanding what we understand about ICOS deficiency. That was a really great choice. Mm-hmm. I think we will go ahead and move on with our first case. Jesse, if you can cue that up. I just want to introduce two of the mentors that have joined us for the discussion today. Joe Church has joined us from California and Patricia Lugar from North Carolina. So we're delighted to have them, and they'll be commenting on the cases. The first one is by a very good friend of mine. I met Carlos some years ago, and he's been very active in immune deficiency in Mexico, and he has a really fascinating case. So, Carlos, go ahead.
Thank you very much. Good night, everyone. I'm Carlos Chalita. I'm allergist and immunologist in pediatrics from Mexico. First of all, I'd like to take the opportunity to present this interesting clinical case. I have been learning a lot from this case, and I'm still learning even more. So, the case is about a girl, 16 years old, when we met her. She was previously healthy. She has not any evidence of autoimmune disease or immunodeficiency in the past. The family history was negative for autoimmune and immunodeficiency diseases. She was the sickest person in her family. So we met her with the initial complaints of fatigue, general weakness, pallor, and edema of lower limbs. When we met her in the physical exam, we found Raynaud phenomena and elevated blood pressure and edema of the feet. The first lab work done in the patient was the CBC, who reported anemia and lymphopenia. The anemia was of the order of hemolytic because we found a positive, very positive CUM test. And the evolution of the patient was very severe because she started to have a lot of kidney complication with persistent elevated blood pressure and elevation of urea and creatinine, and then eventually had low filtration rate who require treatment with kidney replacement with hemodialysis. And the patient had the diagnosis of lupus based on the nephritis. We found proteinuria cellular casts. It's very important to say that the patient didn't have the proteinuria in a nephrotic range. She had also, I mentioned it, a low glomerular filtration rate who required treatment with kidney replacement with hemodialysis. The patient had hematological complications like hemolytic anemia and persistent lymphopenia. She also had pericardial effusion, and the patient also had central nervous system involvement in terms of acute confusional state. She even had seizures, and the MRI showed something related with vasculitis. So the ANA antibodies were positive in low titer and with a speckled pattern. And these are the rest of the lab work done in the patient. It's very important to see that the patient had hypogammaglobulinemia. These are the numbers for IgG, IgM, and IgA. She also had during the kidney flare reduction in complement in C3 and C4, and the rest of the antibodies were negative. It's important to mention that we found very positive urine antibodies, anti-DNA, in the urine, and this was the first evolution of the patient. In the evolution of the patient was very torpid. The patient started to have a lot of infectious and non-infectious complications. The patient had severe sepsis because Pseudomonas aeruginosa. Then the patient had complicated pancreatitis. It required intensive unit care during several weeks, and the patient started to have neurological involvement with seizures, Broca's aphasia, and an acute confusional state 2. Then the patient was treated for an urinary tract infection because Serratia marcensis, and she had a gastrointestinal bleeding with shock. She required hemotransfusion several occasions, and then the patient had another infectious complications with complicated pneumonia who required mechanical ventilation, and one more urinary tract infections with Pseudomonas aeruginosa. During the evolution of the patient, she was treated with a lot of kind of drugs, high doses of steroids and immunosuppressive agents like cyclophosphamide and mofetil, and at the end of the course of the hospitalization, she had treatment with high dose of immunoglobulin in terms of 1 gram per kilo. So these are the questions.
So Carlos, this is Trish Lugar. Can you hear me?
Yeah.
So when she first presented to you her immunoglobulin panel that we saw on the previous slide, she had low gamma globulins at that time. Did you?
No, she was. No, she was not on immunoglobulin replacement.
And she had yet to be treated for the lupus picture?
Yeah.
I think that's important for considering the question.
I'd like to mention that the patient had normal levels of albumin at the beginning of the evolution. Yeah, that's important. Okay. And it's very important to say that the nephritis, it was not a case of nephrotic syndrome associated with the lupus nephritis, that it's producing loss of the immunoglobulin by kidney, right?
Yeah, that's a good question, and we have a couple of folks chatting in that are asking a little bit about secondary causes for the hypogammaglobulinemia. Can you see the chat considering protein loss potentially through the kidneys and wondering about that albumin?
No, there was not.
Okay, so her albumin was normal.
Yeah, it was normal. Yeah. 4.0, yeah, normal.
So, audience, what do you think about this? It's an unusual case. We don't usually think about lupus. It's not usually an immune deficiency. Some people have had some good thoughts. So, what do you think? What would you do next? What are you thinking about this case?
Yeah, so the evolution of the patient was very torpid, and the patient started to have a lot of infectious complications. So we have to go deeper in the study of the patient. So we started to make the immunology valoration, and we saw this was the first flow cytometry seen in the patient. The most important thing in this cytometry is the low levels of B cells, represented by the low levels of CD19 and CD20. This is the MRI of the patient, and it's showing data compatible with vasculitis. So I think that this patient is having two problems, autoimmunity and immunodeficiency.
When was the flow cytometry done relative to steroids and all the other things?
Yes, very good question. The flow cytometry was made when the patient was on steroid and mofetil medication before immunoglobulin replacement, and we don't use rituximab in this particular patient.
So, Carlos, there's some questions here regarding specific antibody titers. At the time the low IgG was noted, were specific antibodies measured for tetanus?
Yeah, that was after. The first thing that we made in this patient is trying to see if the patient produced isoagglutinins. So they were negative in these patients, and then we start to make the antibody response to pneumococcus. So this is the pre-vaccination serotypes for pneumococcus. And after 3 weeks, the vaccination, the patient did not respond very well. Only 28% of the total serotypes of pneumococcus were seen, and it accounts for less than 70% of the normal response in a normal people, you know. This lab work was done before treatment with immunoglobulin replacement.
And at the time
while she was on steroids, I presume?
Yes, with high dose steroids and mofetil, not cyclophosphamide yet.
So, Carlos, prior to her coming in for the presentation, did she have a history of infections as a child?
No infections. She was previously healthy. She started the problem at 16 years old.
All right, so let's get a little interaction from the audience here. So Alexandra, coming to us from the ID perspective, has proposed VZV. And I agree that brain MRI is really worrisome. So Lupus is actually my bench research interest, and I've got to say that it's very unusual to get CNS vasculitis in lupus. You have to be very, very sick with lupus to get CNS vasculitis. That's different than when we say lupus cerebritis, which is more of an encephalitis.
Do you mean that I have to look for any disease like viral disease in brain?
Well, you're going to tell us how she did, but I understand why Alexandra said that, because it's just that vasculitis that you showed us in the MRI is just very worrisome. It's medium vessel vasculitis. It looks terrible. It's not. It certainly does happen in lupus, but it's definitely unusual. So I understand why people are thinking about infectious causes of vasculitis, and there aren't that many infections that can do it. So I didn't mean to interrupt you, but go ahead with your presentation.
No. We didn't do the we didn't find any infectious disease. We didn't get cerebral fluid. Mm-hmm. We talk about it was just lupus related vasculitis.
Mm-hmm.
Mm-hmm. Yeah.
Go ahead.
Okay. So these are the questions. Are we sure that it's CVID? I'm not really sure. She has a phenotype where, the patient is having more autoimmune complications than immunodeficiency complication. It's not a typical form of CVID. I don't know if you have any other comments.
So if you look at Charlotte Cunningham Rundle's data, the patients, so about 3% of her cohort of common variable patients have lupus. It's not a major finding, but certainly seen. And those patients all had lupus before they had common variable. So it's unusual. We usually think about the autoimmune disease occurring after you have common variable, but lupus and about half of the cases of ITP start before the patient is diagnosed with common variable. So I think there's at least a precedent for this type of presentation with terrible lupus and then diagnosing common variable. There is a precedent. I think there are some people proposing other things now.
Because I need that the patients with a CVID can have more autoimmune cytopenias, not lupus, like that,
Yeah. But Patricia, lupus is seen, right?
Excuse me?
Trish, lupus is seen with common variable, right?
Yeah, lupus can be seen certainly with common variable immune deficiencies, and there's a number of questions that are sort of coming in looking at possible pathomechanisms. So I think that I agree with Kate that you can see a very striking autoimmune disease, and then you see when we're looking at patients with CVID, asking the question of if this is acquired form of hypogammaglobulinemia, and then since CVID is a difficult diagnosis to make because it's purely based on clinical parameters for the most part, we're looking for not only the significant hypogammaglobulinemia, but also that impairment of specific antibody production, and a lot of it rests on, this infection history. She clearly has very severe infections with the immune suppression that she didn't have prior to the immune suppression. So it always makes you wonder about different types of selective treatment for her autoimmune complications, but she clearly needs that. Have you guys looked at some additional markers for autoimmune disease and how that might affect immune function, such as specific autoantibodies to cytokines? That was raised by Khan. Is it Priest? I think that's a very interesting question, and whether or not there was some other flow cytometry that looked at potentially T cells or T regulatory cells or other immune B cell subsets that might look more autoimmune? What were you able to expand her flow cytometry panel to look at those?
Yes, a lot of work is missing. The B cell panel cytometry is missing, and the T cell proliferation study is missing. This is an incomplete case yet. This is the first lab work.
Yeah, I think it would be interesting to see if she does have, although it might be difficult now to look for T cell proliferation studies or T cell function after the immune suppression that's necessary to control her disease. It might be somewhat difficult to grab that and believe that data 100%. So I think these are all good things for us to think about. I think the question of whether or not this is truly CVID by the way we diagnose CVID by clinical characteristics with the hypogammaglobulinemia and her poor response to
antibodies,
the vaccine, although she was on fairly significant immune suppression, and she does have significant, so she's certainly symptomatic with her hypogammaglobulinemia. And to be honest, patients who have acquired hypogam from Rituxan or other medications, oncologists and we speak frequently, and they tend not to get severe infections. So that oftentimes, proves to us that sometimes the number itself is not where we need to be so concerned. Although her IgG is quite low, it's really the patient's course, and her profound susceptibility to very severe infections certainly argues more toward a significant immune dysfunction that I think fits with the immune deficiency for sure. We see so many patients who are on so many immune suppressives, and they do tend to get hypogammaglobulinemia with the methotrexate and many, many others, and they really do not succumb to such significant infections. So I think that's a key piece to her course.
I think that's a great point. And I noticed that Luis Gonzalez Granado has had a number of comments here ranging from concerns about could this be a complement deficiency. Then he's raised a number of what we're sort of lumping as dysregulation diseases. So I'm scrolling back to where he was, CTLA4, PI3 kinase. I don't really quite count TACI, but then I think he brought up LRBA. So that's a category of diseases where you get that funny overlap between something that looks a lot like common variable and a lot of autoimmunity. How has this girl's course evolved? Is it too soon to really know if she's going to have persistent autoimmunity? Do you have a sense yet?
Excuse me, Kate?
Carlos, do you think that this girl, this patient of yours, is she going to have more and more autoimmunity, or have you seen her course long enough to be able to decide that? Does it seem like she's going to have persistent problems with autoimmunity, or she had her bad lupus and now she's better and it's really just a common variable?
Yeah, the evolution till now. The patient is under control. She's on mofetil and steroids. She hasn't had any flare at all the last 2 months. And she's on immunoglobulin in high doses, 1 gram per kilo, and she's doing pretty well till now. I don't know what will happen in the future.
How long has it been since her lupus presentation?
1 year.
1 year. So that's pretty good. Most people, when they get Cytoxan for lupus, you start to have some of the effects wear off at about a year. So I think hopefully that means that she's gotten good control. But the prognosis for a 16-year-old that presents with lupus that severe is not very good, regardless of what the cause is.
Now,
what else do you want to tell us about your patient?
Okay. So next slide.
Yep.
Okay. So this a little move. So, but I conceive CBID like this big dog who is having 3 heads, autoimmunity, immunodeficiency, and cancer, I see like that. And there are certain kind of immunodeficiencies related in a stronger way with autoimmunity. CBID is one of those. And that's it.
Are the parents related at all?
The parents what?
Are they related by blood? Are they related?
No, there is not consanguinity, no. To think about a recessive form of immunodeficiency, no, they are not related.
And Carlos, with her control of her disease as of now, there's a few comments also coming through. Folks wondering about, has her autoantibody status returned to normal, her complement level turned to normal, overall the markers of her disease? Has that normalized? Because that would help us with the concerns for the differential diagnosis. Although we can't get T-cell proliferation studies to look for some of the genetic associations that are more likely to be a combined immune deficiency, we can look to see if some of those complement levels and other of the abnormalities initially found had returned to normal?
Yeah, the complement levels are actually normal, and the ANA antibodies are negative, and we don't have still T-cell proliferation lab work.
Okay, and her kidney function is normal with the marker for the DNA antibodies in the urine is cleared?
Yeah.
Okay, so I think that's important, going back to the initial differential diagnosis when we're thinking about so many the complex features to this case, and thinking about possibly complement deficiencies as a cause for both, for example, complement 2 deficiency and autoimmunity and antibody deficiency. So that certainly would be suspicious that she does not have that.
Yeah, that's true.
And her IgG with the high dose IVIG, has it stabilized to what level?
Yeah. There are not infections, and the plasma level is actually normal.
So what do you plan level of IgG?
What?
Sorry, I misunderstood what you said about the plasma level.
Yeah, the plasma level actually is normal on immunoglobulin replacement.
Okay.
And so also is a question, Joyce, it's a very good question. She said about the B-cell flow cytometry. So initially, the B-cells were low. Have you remeasured them?
Yes. We made another 2 flow cytometries, and they keep in a low level.
She has persistent low B-cells.
Yes. In 3 determination, she had low levels of CD19 and CD20 B cells.
I think that's hard, though, because Cytoxan will really deplete your B cells, not as much as rituximab, but Cytoxan is pretty B cell toxic.
Yeah. She has not rituximab yet.
Mm-hmm. And with oh, sorry.
No, go ahead.
With the immunoglobulin replacement, her IgA and IgM, are they trending the same, low or normal?
Yeah, low, normal.
So in the presentation, both just the IgM was low and the IgA was normal, and her IgM remains low?
Yeah.
Okay.
The only to normalize is IgG after the replacement.
Okay, very good. And Joyce had mentioned, did you measure isotype switch memory B cells?
No.
Was that available?
No.
Okay.
Not yet. I haven't done the B cell component yet.
I think it's going to be really interesting to see how she evolves. I think in a lot of ways it's just going to be time that tells you what it is her underlying defect is. I wanted to come back again to, I think it was Luis who commented on the immune dysregulation diseases. So just to be sure everyone's up to speed on those, there's about 5 or 6, depends on how you count, but there's about 5 or 6 new gene defects that have been identified in about the last 3 or 4 years that do represent this sort of funny common variable-like phenomenon with autoimmunity. So just to run through them all for everyone in the audience. So haplosufficiency for CTLA-4 is probably the most common. About 3/4 will have hypogammaglobulinemia. Autoimmune cytopenias are extremely common, and they do have low B cells with low naive T cells, so actually would fit this patient fairly well. There's also LRBA deficiency that a couple of people commented on in the chat box. That can look very much like CTLA-4 deficiency, and in fact the mechanism is thought to be quite similar. You tend to get a lot of GI tract autoimmunity. There's NF-kappa B2 deficiency, which is autosomal dominant. Here, they uniformly will have adrenal insufficiency, susceptibility to herpes viruses, which might come back to Alex Freeman's comment about could this have been varicella, and hypogammaglobulinemia. And then there's PI3 kinase P110 delta, gain of function, usually a lot more lymphoproliferation than what we've seen in this girl, but a lot of cytopenias. So really, again, could be consistent with this picture. And then there's the very close relative PI3 kinase, the P85 regulatory subunit, virtually identical phenotype to the P110 deficiency. So both of those tend to have low T cells, but then have relatively normal B cells with low switch memory B cells. So for those of you who haven't heard of these monogenic diseases, I would urge you to take a quick look at those 5 at least, and then you can add others if you feel like it. They are becoming increasingly recognized, and I think especially CTLA-4 deficiency is common enough that you will see it at some point. So I think we will close out this case and move on to Jen Heimell, who has another really interesting case, but totally different.
So thanks for giving me the opportunity to talk with all of you about SCID with a twist tonight.
Get out of the way of that.
So, is that okay? Should I keep going?
Yep.
Okay. So this is a patient who was referred to us. I'm from the Children's Hospital of Philadelphia, so it was a Pennsylvania state identified SCID newborn screen patient, and she had a TRK count less than 25 and was sent to us for further evaluation. She was a full-term Caucasian female, and she was the first child to her parents. There was no family history of SCID or any other immunodeficiency for that matter. However, her father did have some learning disabilities and language impairment. And there was no consanguinity. Her initial physical exam was notable for having scant tonsillar tissue, for as well as you can really assess that in a newborn. A very slightly abnormal positioning of her ears, maybe a bit of posterior rotation and some folding of the pinna, and some notable micrognathia. So, with those findings, there was nothing in particular, but there was something in particular we were thinking of. I don't know if we wanted to talk about that, or we can save that until I get the first set of labs. And there was no maternal use of any immunosuppressives, and she did not have any cardiac disease. She was feeding well, growing well, was breastfeeding at the time that we saw her. So we then, I'm going to hit the next one here. We then went ahead and got an initial set of labs. And so, as you can see, what we found to be notable, she had a normal WBC. Her ALC was, lower than we would want to see in a newborn. She had an 8% eosinophilia, so a bit high. And then her CD3 count when we did the flow, she certainly had a low, but not to a typical SCID level low of T cells. And she had a relative kind of even portion of CD4s and CD8s, and similarly a higher number of memory type T cells, the CD4 and CD45 RO T cells were certainly a higher proportion. Usually we would have expected that to be closer to a 10-to-1 comparing the RAs to ROs, and this is really more like 1.5 to 1. She didn't have any increase in her. Sorry.
Can I ask what was the TREC count?
The TREC count, we aren't able to get a specific number in Pennsylvania. So what the lab will report out to us is, was it less than 25? Was it between 25? Between 25 and I think it's 50, and was it over 50? And so hers were less than 25 is all we were able to get from them. And then we also noted her to have low B cells with normal NK cell populations. Her immunoglobulins, which obviously the IgG at this point is primarily maternal in origin, were notable for slightly low IgA, IgM, but nothing striking for a newborn. And when we looked at her mitogens, in our lab, the PHA count per minute normal range for the patient for pediatrics is to be anywhere between 35,000 to 100,000. So she was in that range. If we compared her to the control for the day, they had similar background, and she was about 50% of what the control had done, but certainly nothing too striking there. So I see a couple people have raised the question of DeGeorge, and that was certainly a big point for us to eliminate, given the physical exam, the family history, and some loss of T cells. So what else is everyone else thinking of at this point? Any other thoughts?
So I see some great stuff rolling in. DNA ligase 4, omens. I saw a couple of DeGeorges, a charge syndrome. What else are people thinking?
We don't have corrects. I see the question. We did not have the ability to do those.
My first impression with abnormal flow in a baby is maybe the lab did something funny, maybe there's something else going on, and we just watch the kid for a couple of weeks and repeat it. And if it was a persistent T lymphopenia type of thing, TB lymphopenia, then we'd go a little bit harder.
Let me just stimulate a little more discussion here. So there's a lot of votes for DeGeorge, and I'm just going to key on this DNA ligase 4 deficiency from Lahari. Clearly, Lahari picked up on something that the DeGeorge people didn't. So I'm guessing that Lahari noted that low B cell count that you were talking about, Jen. At the time, what was your take on the low B cells?
So at the time, we were concerned about it, but my first thought was to kind of go with what George said, with what Joe said, and repeat it. Our other consideration was that could there be some level of maternal engraftment here that was causing an autoimmune phenomenon if this was an atypical DeGeorge and causing some level of B cell destruction. So we did a few additional studies to help try and tease some of those things out.
Okay, you want to tell us about those? I think Carl has
Sure.
a great question about a chest X-ray, but I think that might be coming up, right?
There was a chest X-ray. I don't have the image, but I can tell you there was no crime scene. I didn't actually even include the chest X-ray in this presentation. But there was a chest X-ray, and there was no visualized thymus. So we did testing and looked for HIV. We looked for a deletion by array for a deletion in 22q11.2 to look for DeGeorge. We also did look for maternal engraftment. All of that was negative, and we repeated a trek with Mayo Labs just to give frame of reference. And so their normal in a newborn would be to be over 4,000, and it came back at 846. And so at that point, and we had also repeated the flow cytometry panel and found pretty much essentially the same numbers. It was at that point that we went ahead and pursued doing the genetic testing. While the genetic testing was pending, because obviously, right, we got a lot of this stuff back right away, but when you send off your genetic testing to the commercial lab, it takes some time. So we had started her ready on Bactrim and fluconazole prophylaxis at that point. And we had also initially, when we got the first set of flow back, had mom hold breastfeeding, but then she turned out to be CMV negative, so she actually resumed breastfeeding. But then we got back her report, and she was found to be heterozygous for 2 mutations in RAG1, one being a protein truncation mutation that has not previously been reported, and one that is a missense mutation that has previously been reported to be associated with other hypomorphic SCID or Omen syndrome presentations.
And how did the eosinophilia evolve? Did she sort of evolve more into an Omens-like picture, or
was
that sort of a little blip?
That was a little blip, thankfully, for her. And so we did not have a need to treat her with immunosuppression, although we certainly were monitoring for that over time, with each set of flow that we did. And we kind of brought her back on a monthly basis to reassess things. So we saw her initially at about 2 weeks of life. I guess it was a little bit more than monthly because we saw her at 2 weeks of life, and we brought her back probably a week later to get this second set of CBC and flow and to look for the 22q and maternal engraftment and the repeat trek. And then when those all came back negative, we had her come back 2 or 3 weeks later, got another CBC, and at that point did the sequencing, and then just kind of followed her on a monthly basis, in part because it was the winter months. We were checking in with the family at home, but she was clinically doing well. There were no siblings. There was nothing in the home. So without her having clinical problems, we didn't want to expose her to being in a clinic setting. And I see the question about were the parents sequenced. They have not yet been sequenced. It's certainly been something we've discussed with them, but it's not something they're interested in doing at this time. But it's been thought of.
There's been some interesting discussion recently about how the computer projection of genetic finding may not, in fact, be right a lot of the time. And so that raises the issue with this. It has this particular mutation or variant hasn't been reported before to be associated. And is it, in fact, a pathologic mutation? And really probably the only way to be pretty sure is to do the parents. You have one on each parent, right, and you can be pretty sure that it's not good to have them both. The other thing is I think there's some patients that the second mutation in RAG was not identified, and that patients with just at least identifiable heterozygosity in RAG1 can be associated with significant immune dysfunction.
Mm-hmm. Right. So our concern was, she did have low level but not negligible eosinophilia, and so on some level she seemed like she was a bit of a ticking time bomb for when we might potentially have an expansion of what was a predominance of memory type T cells, and then really find ourselves in trouble.
Mm-hmm.
I think you've got some more story to tell us.
Yep. So, what do folks think about transplanting this patient?
So she's got some T cells.
I may not have, I don't know how fast you did the transplant. We probably would have immunized her a couple of times since she's in a relatively safe environment at home. Obviously, rota, but see if she could make antigen-specific or tetanus-specific antibody or lymphoproliferation.
So we did not do that. She was, like I said, she was maintaining her numbers, but she was in this very clamped down isolation state, and kind of at home. So we did opt to transplant, and we opted to try to have her transplanted sooner rather than later because this was occurring, during the high viral season, and felt that if at all possible, it made sense to try to kind of get her in and taken care of.
Let's do this. Let's go back to these labs that you just showed.
Yep.
And just leave them up for just a sec. And let's just ask the audience. So you've heard two people. One, Dr. Heimall felt that, relatively urgent transplantation was really indicated. There were RAG mutations identified. She had a demonstrable, clear, combined immune deficiency. And then Dr. Church say, well, let's test her. Let's use the tools that we're accustomed to using, vaccinate her, reassess her periodically before we make any decisions. So let's just take a quick poll in the audience. Who would have transplanted soonishly, without defining what that means, and who would have been more circumspect and really done significant testing before they considered a transplant for her? So let's just take a quick poll to see where people are at, and the reason I'm doing this is that there's not a perfect answer. We know that early transplant for SCID is beneficial, but this is clearly a little bit more of a gray zone. So let's just sort of take the temperature of the audience and see what people are thinking. And again, there's not a right or wrong here. It's just, everyone's taking their best shot and trying to do right by their patients.
Right, and you're going to be
doing a Khan's point is really good. I think it's variable depending on the match, what you would want to do too.
Yeah, we're looking at kind of a 50-50 split here.
Yeah.
Interesting. All right, Jen, why don't you tell us how this evolved?
Oops. Now I just got all ahead of myself. All right, so we did go ahead. She had a well-matched umbilical cord. She had no other donors available that were a full match in the registry, and so that actually really helped push us toward the decision to transplant, because we were concerned that if she got larger, and we kind of waited this out, that potentially the cord might not have been enough of a cell dose for her, and I don't recall what the dose was off the top of my head. So she was treated with 8 of fludarabine 1.3 mg per kg and ATG 1.5 mg per kg, and then for GVH prophylaxis, she got cyclosporin and CellSat She had some very mild skin graft versus host disease acutely, but has no chronic graft versus host disease. She is now doing spectacularly from both immunologic and a developmental standpoint, and she's off of IVIG and receiving her vaccines. And her immunoglobulins are all completely normal for her age. She's 100% engrafted. She has, a very robust CD3 count with a nice RA to RO proportion, and she's exhibiting development of memory B cells. So we're pleased that she has clinically done well.
Great.
I would say we totally agree with everyone that we would like the parents to be sequenced. They're not interested in pursuing it right now, but totally agree with everyone that would be a really good thing to do. And so I just thought that kind of the key points that this case really illustrated were that it was the low B cells without any evidence of maternal engraftment and having these moderately decreased T cells, but with nothing else to really explain it, is what made us kind of push further and look for the genetic testing for a T negative, B negative, NK positive type of SCID. And we definitely wanted, in this scenario where, she wasn't acutely sick, it wasn't a typical SCID, we had the time to spend to figure out if this was a radiosensitive SCID or to try to have a genotypic diagnosis rather than just going on a phenotypic diagnosis. And that, I think, enabled us to feel more comfortable going for that umbilical cord blood where we knew we were going to have to use some level of myeloablative therapy to get engraftment of the cord. And just, from the recent GEM article, just to point out that RAG1 SCID is the most common form of hypomorphic SCID that's being identified in patients who are, to use the same word, identified by newborn screening, and it's actually about 10% of the typical SCID. And then Joanne Walters had her recent paper out that, really shows there's a lot of autoimmunity and granulomatous disease that can present later in life. And I think, that those can be really hard to wrangle under control if they get to be out of control and they start to really manifest themselves. So on some level, thinking about the potential that was where this child might go also helped us, feel more comfortable pursuing the idea of a well-matched transplant. My other main point is that knowing that genotype is really helpful in your decision-making process.
It's a really great case. So do you want to circle back to that red herring of the micronaphia and the
yes.
overfolded ears? Carl brought it up, and I think it's worth just circling back to that.
Yeah, I agree. Most rag babies do seem to look normal. I will say she seems to, we see a lot of 22q. Her ears definitely still look a little abnormal, but I think she's grown more into her chin. It wasn't this profound micronaphia, and all babies on some level do have a little bit of a small-ish chin. She was evaluated by ENT. They followed her for a little bit, but ultimately they didn't feel that it was something that was going to really cause any impairment to her. She didn't have any choanal atresia or anything in that regard. And she doesn't have other features that, necessarily made us pursue a syndromic, genetics counseling from a syndromic perspective. I can't say that we've necessarily done much else. She's had normal hearing testing. Her ears, like I said, their placement is slightly off, certainly, I think. But I don't have a perfect explanation for why that's there, because I agree, our other rag babies often are very, very typical looking.
Yeah, I wonder if there's any way to put it together with the hearing loss in the father. Is there anything that might sort of have that diversity of phenotypic expression that would be autosomal dominant?
Not. That's going to mind for me right now.
Well, there's nothing in my mind either. It wasn't a trick question. There really wasn't anything in mind. Atusa raised the concept of a duplication of chromosome 22, and so I just wanted to key on that. We're actually a little bit over time, but duplications occur just as commonly as deletions, and as Atusa correctly points out, the FISH test will not find the duplications, only the SNP arrays. Do you remember, was it an MLPA that was done for your baby?
Yes. Yeah, no, we did do the array.
So that does pick up on the duplication. So I think you've done your due diligence in terms of sussing out what that micronaphia and low set ears were all about. So I think we should finish up. We are a little bit over time. I want to thank the presenters very much. Amazing cases, really great job. I definitely want to thank the mentors, Joe Church, Trish Lugar. Thank you very much for your comments and your insights, extremely helpful. And I want to say good night or perhaps good morning to some of our friends. So certainly welcome very much to the person from New Zealand and, of course, all of our friends in Mexico and South America. I saw Brazil and Peru for sure, and then everyone from across the United States. So thank you all for joining so much. We look forward to seeing you probably because of the holiday. The next one will be the first week of December. So think up some great cases for us and let me know if you want to present. And have an excellent evening or good morning wherever you are. Take care, everyone.